We have congenitally corrected transposition of the great arteries atrioventricular and ventriculoarterial discordance. The fetus is in a cephalic presentation with the back on the left side. That is, in this image, we can see that there is a double atrioventricular and ventriculoarterial discordance, such that the blood that arrives without oxygen to the right atrium will pass through the mitral valve to the anterior ventricle with left morphology, which would be the left ventricle. And from this ventricle, the pulmonary artery will emerge to go and be oxygenated. The oxygenated blood that reaches the left atrium will pass through the tricuspid valve into the posterior ventricle with right-sided morphology, then exit through the aorta and go to the systemic circulation, so the circulation is congenitally corrected. The etiology is heterogeneous and multifactorial. Familial cases account for less than 5%, or it may be sporadic. It has a low frequency and represents less than 1% of congenital heart diseases. The types are 95% corrected transposition of the great arteries with N, and in 5% there may be dextrocardia. Corrected transposition of the great arteries can be simple in 30–40% of cases, and it can be complex when it is associated with ventricular septal defects in 50% of cases, stenosis, pulmonary artery atresia, or Ebstein's anomaly. Let's analyze in detail this video clip of a basal four-chamber view. Here we have a case of congenitally corrected transposition of the great arteries, where we can already see that the right atrium communicates with the anterior ventricle, which has smooth morphology, through the mitral valve with a ventricle of smooth morphology. In other words, there is atrioventricular discordance. And the posterior atrium, which is the left atrium, communicates through the tricuspid valve with a ventricle of right morphology. Therefore, this heart condition is also called ventricular inversion because the ventricles are reversed. The anterior ventricle is the left ventricle and the posterior ventricle is the right ventricle. It is L-transposition. So here we can see in these two images that there is a double atrioventricular discordance, image on the left, and ventricular-arterial discordance, image on the right. The pulmonary artery emerges from the left ventricle and the aorta emerges from the posterior right ventricle. Here we can clearly see how the pulmonary artery emerges from this ventricle and bifurcates into its two branches, the pulmonary artery and the aorta. And here we can clearly see, and there we can observe the two vessels side by side in parallel, double discordance. Another example, here the fetus is in cephalic presentation with the back lateral to the left, and we see a four-chamber view that appears normal, but it is not normal. Here there is atrioventricular discordance and ventricular-arterial discordance. Additionally, what stands out is that there is a rhythm disorder. There is an atrioventricular block. There was a TOOM1 atrioventricular block with an atrial rate of 142 beats per minute and a ventricular rate of 72 beats per minute. A pacemaker was placed in the newborn for this patient. And here is the image from the same case, meaning the video from the same case. Cephalic presentation, left lateral back, and here we see the atrioventricular discordance, as I already mentioned in the other examples, and the discordance. Now we are going to look for the outflow tracts, and the ventricular arterial discordance will be seen. Double atrioventricular and ventricular arterial discordance. There it can be clearly seen that the pulmonary artery arises from the anterior ventricle, the left ventricle, and the aorta arises from the posterior ventricle, RV. Another case, the fetus is in a cephalic presentation with the back laterally to the right, and we see a slight marked levocardia there. Please observe the four-chamber view here. The right atrium communicates through the mitral valve with a smooth morphology ventricle, which is the left ventricle. As you can observe here, the left atrium connects through a tricuspid valve to a posterior ventricle with right-sided morphology. Therefore, we would also be dealing with an atrioventricular discordance. Let's move to the outflow tracts. Here, in this view, we can see that the atrioventricular valve is more apical than the mitral valve because it is discordant. The tricuspid valve follows its ventricle, therefore the tricuspid valve is in the posterior ventricle. In addition, patient had a perimembranous ventricular septal defect and a large muscular VSD. When we were trying to assess the outflow tracts, there was also ventriculoarterial discordance. And what stood out was that this vessel, which is the aorta, arises from the posterior ventricle with right-sided morphology. There is an atrioventricular discordance in the arterial ventricle. The pulmonary artery is difficult to identify. Here you can see the large, wide muscular VSD. This would be the aorta emerging from the posterior ventricle. And please notice here, on this view, we can see the pulmonary artery. There is atresia of the pulmonary artery. Essentially, the pulmonary trunk cannot really be seen, but it is emerging from the anterior ventricle. Therefore, there is a double atrioventricular and ventriculoarterial discordance. Therefore, we would suspect a congenitally corrected transposition of the great arteries with a muscular ventricular septal defect and pulmonary atresia. You can see it better there. Here you can see that the aorta arises from the left ventricle, that is, from the posterior ventricle with right-sided morphology, and that the pulmonary artery arises from the anterior ventricle with left-sided morphology. Corrected transposition of the great arteries. In this patient, the fetus presented with tachycardia at 36 weeks and arrived at the emergency department with 280 beats per minute. She underwent an emergency cesarean section. The newborn had an APGAR score of 808, and the heart rate once born was 140 beats per minute. The diagnosis? Congenitally corrected transposition of the great arteries with pulmonary atresia, a muscular VSD, and mild tricuspid and aortic regurgitation. He received prostaglandin and required a Blalock procedure.